The YouTube channel has already started relaying us. Shall I start, sir?
Yes, please.
Yes, sir. Okay. Honorable Director of the Sri Chitra Tirunal Institute for Medical Science and Technology, Dr. Sanjay Bihari, Dr. Ajit Kumar, the Dean of the Institute, esteemed members of the faculty, guests who are with us online, and my dear students. Good evening to all. Relations and relationships are unique to human life and renders a great sense of comfort and sometimes otherwise as we live our lives. The doctor-to-patient relationship is sacrosanct and central to our lives as we practice the noble profession of medicine. We have today with us a distinguished doctor in our midst as we begin our Chitra lecture series, Samvaad, by the learned members of the civil society, hosted by the Sri Chitra Tirunal Institute for Medical Sciences and Technology. I invite Dr. Ajit Kumar, Senior Professor, Department of Cardiology, and Dean of our institute, to start the proceedings with his introductory remarks. Over to you, sir.
Good evening to all of you. Respected Director Dr. Sanjay Bihari, respected Professor Sunil Pandya, Professor Ishwar, HOD Neurosurgery, Professor Mara Ramanathan of AMCHS, esteemed faculty, colleagues, and my dear friends. Good evening to all of you. It is my honor and privilege to welcome all of you to the first talk in the Samvaad International Lecture Series from the Sri Chitra Tirunal Institute. Though the Institute focuses on biomedical technology, postdoctoral training, and tertiary hospital care, we take exceptional pride in patient care primarily. I should tell you that the Institute, fondly known to the public as Sri Chitra, is dear to patients from this part of the region, not because of the technology and the interventional surgical expertise it claims, but from the edifice of trust that the patients have built over the years, that we will take care of them in an ethical manner, no matter who or what he is. Here at Sri Chitra, after Professor Sanjay Bihari has taken over the reins of the Institute, we are happy to announce certain fresh academic changes, and the first of which is the Samvaad International Lecture Series. Now, this plan will encompass talks in the fields of academics, ethics, research, management, and technology by leaders across the national and international arena. And the first talk of the series, a humane doctor-patient relationship, will be by respected Professor Sunil Pandya, eminent neurosurgeon, who is highly respected for his contribution to ethical medical practice. Dr. Ishwar, HOD Neurosurgery, will soon introduce Dr. Sunil Pandya. Now, I will, by privilege, dwell a moment on the topic of concern here, that is a doctor-patient relationship. A visit to a doctor is not an intellectual cognitive exercise by two individuals and a computer, but it is a complex human-to-human interaction. And as Dr. Abraham Verghese put it, it is a ritual. And when that individual patient seeks help from another individual, that is a doctor, and confides in that person, and then incredibly disrobes and allows touch, it is not a mere cognitive exercise, but it is a ritual, a relationship that conveys to the patient a sense of the physician's commitment to being there to help and alleviate his pain, never abandoning the patient. And it is this trust that the patient conveys that is the basis of the humane doctor-patient relationship, which we are going to discuss. I will not go into further details and discussion. Professor Sunil Pandya will enlighten us on the topic. And over to Professor Ishwar to introduce the speaker. Dr. Ishwar, please.
Thank you, sir. Dr. Sunil Krishnalal Pandya has had his medical training, basic medical training at the Grand Medical College and the Sir JJ Group of Hospitals. He had his training in neurosurgery under the legendary Dr. Gajendra Singh at Bombay. It was as it was known those days. He also had a stint at the Institute of Neurology, Queen's Square in London. He was a faculty and later professor at the St. G.S. Medical College and the KEM Hospital at Parel, Mumbai, famed for its academic expertise. Following his superannuation from the medical college, he joined the Jaslok Hospital at Mumbai and is currently working as a senior neurosurgeon there. He was part of the editorial team of the National Medical Journal of India and the past editor of the Indian Journal of Medical Ethics. He was the one who took the task. He was one of the few people those days who took the task of communicating with his patients very seriously. What I understand from his erstwhile colleagues and juniors is that he used to draw and talk the complex neurosurgical scenarios to the patient's families and share with them a copy of the examination that he had performed on the patient, which was unknown in those days. Another facet of his personalities, which is very interesting, is kind of creating the history, writing down the history of what is happening around him. As Indians have always been accused of being very poor in maintaining a record of our history. We always believe outsiders, visitors, and especially with Western literature for what is happening in our past, what has happened in our past. Dr. Pandya was a study in contrast to this phenomenon. He has had the history of his alma mater, the Grand Medical College, written down in good words of his, and also traced the development of medical services in hospitals in Mumbai. He was also written a history a history of the medical ethics practices in India. As the founding editor of the Indian Journal of Medical Ethics, Dr. Pandya has published a lot of work in the area of ethics, which was relatively unknown when he took it up in journals and lay publications. He has nudged the medical community to go in the direction of ethical medical practice. He continues to write on ethics in journals and other publications. Over to you, sir, Dr. Sunil K. Pandya, a neurosurgeon, teacher, historian, and most importantly, a gentleman nonpareil. Over to you, sir.
Thank you. Thank you, Dr. Ishwar. I'm very grateful for this opportunity to discuss a subject which is close to our hearts. Certainly all those who are present today at this meeting, and all of us have a very deep desire that we do our very best for the patient who entrusts her or his life into our charge. Since I am from the field of neurosurgery, the patient who entrusts herself or himself to me is actually quite consciously allowing me to operate upon the most important parts of the body, namely the brain and the spinal cord, and does so with full trust that I will do my very best for her or for him. And it is the justification of this trust which will form the topic of discussion today. How do we justify the trust which the patient places in us? And I don't mean the patient who's a multimillionaire or who's a minister or who's a senior bureaucrat. I'm talking about the poorest of the poor. And when that person entrusts herself or himself to you, the burden of responsibility is immense. And we have to do everything possible to justify that trust which has been put onto us. So I've entitled this talk, A Humane Doctor-Patient Relationship. And it is partly based on a quotation from one of the works of Hippocrates. And as you can read on the screen, wherever the art of medicine is loved, meaning whoever is trying to practice medicine to the best of his ability, such a person automatically has a love of humanity. So that is the quotation which Hippocrates had written about 400 years before the advent of Christ, long time ago. Now, why is such a discussion necessary? Why should we need to discuss ethics and morality and humanity and care of the patient? And that is because, unfortunately for us, in most of our medical colleges, the humanities, ethics, history, philosophy are not considered topics of relevance or of importance. This cartoon, of course, is somewhat drastic in the manner in which it shows the respect with which we treat these humanities. There are, of course, some exceptions, and I've listed those exceptions below. Let us start with some definitions. The humanities has been derived from the word human. And the word human is, in English, has been derived from the Latin word humanus. Now, who is a human being? Which means we are trying to distinguish between a human being and an animal, or what we in derogatory terms, in derogatory and supercilious manner term animals. Human beings are blessed with an inherent sense of right and wrong. We are born with this kind of a sense of right and wrong. And this sense of right and wrong is not an irrational sense. It is a sense which is based on reason. There is logic behind the separation of what is right from what is wrong. It is unfortunate that in the process of education in schools and in colleges and elsewhere, this inherent sense of right and wrong gets derailed. And when it gets derailed, then of course all kinds of anomalous behavior follows. The word humanity is derived from the Latin humanitas. And humanitas is the Latin for human nature. And what is human nature? Human nature is characterized by all the qualities which we love and we respect. Kindness, affection, sympathy and empathy, which are two different meanings completely, harmony, and a sense of justice. Now, these are the qualities which we value in other people. So if I am a patient and I have a doctor who displays these criteria, I'm immediately at comfort. I am in good hands. I know I am in good hands. Now, the word humanities is a more comprehensive word. It includes the branches of learning. And amongst the branches of learning, I've listed a few over there: ethics, history, philosophy, languages, and so on. It also includes the arts. It includes literature. It includes the visual arts, painting, sculpture, and all that. Performing arts like music, drama, films, etc., and other such. And the last and the most important, which is not often included in the description of humanities, is a sense of humor. And you can imagine that a sense of humor can work wonders in many, many difficult situations. And particularly when, with a sense of humor, you poke fun at yourself, when you make yourself the victim of a story or a tale or an anecdote, you're breaking the ice in a very, very natural and very, very beautiful manner. So we will deal with some of these humanities in a couple of minutes. Why are the humanities needed? Why do we need to be human? Why should we be? First of all, because we are doctors. And because our goal, our professed and stated goal, is the welfare of our patients. This itself makes it necessary that the humanities percolate in our being. And here is a quotation from a very distinguished British novelist and essayist: "The humanities enrich the competences that daily life requires and provides." And these competences are very, very magnified and very, very acute in physicians, surgeons, and everyone in the medical profession, medical, paramedical profession. So these competencies are enriched when they are tempered by the humanities. And he has used a very interesting phrase that as far as we ourselves are concerned, the humanities irrigate the deserts that our life has become. Imagine the life of an ordinary clerk or a peon. He goes to work early in the morning, he comes back late at night. He's been doing drudgery all his life. Work which has no imagination, work which has no redeeming feature at all. But if that person and others like us, if we are fond of the humanities, and if we try and get the maximum that we can from the humanities, these deserts start flourishing into greenery, into flowers, into color, into music, into art, into so many other beautiful things. Now imagine two different circumstances. Imagine a doctor, I am the patient, and imagine I'm imagining two doctors who are likely to treat me. Both of them are very competent. They're extremely competent in their fields. But one of them is a grumpy, grouchy person who doesn't really care who I am, who doesn't bother to ask what I'm doing or what I'm fond of or what I like or what I dislike, and is generally speaking a difficult individual. Imagine another doctor who comes in with a smile and with a cheer, walks up to my bed and says, "Hi, I'm glad to see you, and I'm going to do my very best to help you." And he shakes my hand and he asks me a little bit about myself, and he's genuinely interested in me. Can you imagine which of these two doctors I would prefer? So that is what the humanities do. I want to share just 2 or 3 examples of humanity. And one of the examples I'm going to share is an example which is very close to your institution. It is actually a part of your institution. And that is about the history and philosophy of medicine. I understand that Dr. Valyathan has visited your institute in May, as recently as last month. And so you are very, very familiar with it, and all of you know him very well. And I'm showing you just 3 of his books. So you now belong to an institution where your director has done exhaustive research in the Sanskrit literature to be able to produce these 3 books, which have been applauded not only in India, but throughout the world. So you already have a great heritage as far as the history of medicine is concerned, the philosophy of medicine is concerned. And I would expect that each and every student and each and every resident and each and every postgraduate will follow up and build on what Dr. Valyathan has done, and will in turn contribute to the history of your own field in whatever humble way you can. Here's my second example from the humanities, and that is music. Some of you may already know about Dr. Rajendran. Some of you may also be very fond of her music and have listened to her performances because she is a very eminent performer of music. But she is also an oncologist. And she has created this program called Oncology and Strings. And she is using music to help patients with cancer, particularly patients with advanced cancer, patients who are uncomfortable, patients who are in pain, and trying to help them through the field of music. Let me now turn to the second part of our topic, and that is about medical ethics. Here are some definitions again to set the ball rolling. What is the meaning of ethics? What are ethics? And the wise physicians who have preceded us have given us some very good insights into what constitutes ethics. Ethics are the innate, inborn, already present within us universal, that means not localized merely to Trivandrum or to Bombay, but throughout the world. Principles which are within us, principles which are universal, and principles which are moral. And these ethical principles govern our behavior, and they are especially relevant in the field of medicine. Now, you will then ask, what is moral? Moral is that internal compass which helps us to differentiate this is right and this is wrong. The compass merely differentiates them. It's up to us whether we are going to follow the right path or whether we are going to follow the wrong path. And it's the principles of ethics which make sure that we stay true to the right path of moral principles. Now, in the late 1970s and 1980s, two American medical ethicists and philosophers promulgated their version of what constitute medical ethics. You will find their names right at the bottom of this slide, Beauchamp and Childress. And they produced a book which was originally called The Principles of Medical Ethics, and the later editions, they have changed medical to biomedical in consonance with a general change all over the world. They laid down the principles which are followed almost all over the world today as the principles of ethics. The first principle that they talked about was the autonomy of the patient. What does it mean, autonomy of the patient? It means that the patient has the final say in what is going to be done by way of treatment to his body. The final authority to decide about whether or not a proposed form of treatment will be followed lies with the patient. Now, a patient is not a medical doctor. So when an ill patient comes, then we have to advise the patient, inform the patient about the nature of the illness, and then give our suggestion as to what the form of treatment will be. Let me take a simple example, acute appendicitis, where the appendix is about to rupture. So we explain to the patient, look, the pain in the right lower part of your abdomen is because there is a part of the intestine there which is severely inflamed. And if we don't do anything, it's going to burst. And if it bursts, then of course your entire abdominal cavity will be full of pus and it will be a very difficult situation to handle. So our recommendation is that we should do an operation and we should take out this inflamed appendix so that it doesn't burst. The decision about whether the operation should be done or not lies with the patient. And it is the patient's right to say, after having understood everything that you have told him, no, I don't want this operation. And you tell him, look, if you don't undergo the operation, you may die. So he's saying, that's okay, but whatever it is, I don't want an operation. You treat me by any other method, I'm okay, but no operation for me. Fortunately, in this particular instance of inflamed appendix, the medical management of acute appendicitis has now improved so much that there are times when we are able to manage to avoid an operation. But this is just an example I've given you. So for the patient to exercise autonomy, the patient needs information. And that information has to be provided by us in a form that will be understood by the patient and the family. Naturally, after having given this information, before undertaking any kind of a hazardous procedure, we have to obtain what is now called the informed consent. The next principle that they enunciated was that of confidentiality. Many times, the patient will tell us, the physicians, about events in their life which they would not tell their parents, they would not tell their spouses, but they will tell that to us. They tell that to us because they know that it is important for us to have the information in order to be able to treat them. For instance, a man may come and tell you that I had visited a prostitute 17 times in the last 1 month. Now, this is something he will not tell anyone else because it's not something which he's proud of. But he will tell you. This information and any other information which the patient gives you in the course of a consultation is confidential between you and the patient. And you will not divulge this information to anybody. There are certain exceptions. If there is time during discussion, then we can discuss some of those exceptions. The third principle is two sides of the same coin. The first side of the coin is beneficence. Beneficence is a long word for saying doing good. Whatever we do to the patient should always be aimed at doing good to him. What is the other side of the coin? Non-maleficence. We will not do anything to harm the patient. So there are two sides of the same coin. Doing good, not doing any harm. Now, these appear to be absolutely self-evident principles, but you'd be surprised as to how many of us doctors sometimes will willingly do things which can harm the patient. I'll give you one example, an operation which is not indicated. A patient comes to us with some symptom and we say you need an operation of this kind and that kind and that kind. But that operation is not really needed. Then why do I tell the patient you need an operation? Because if I get to do that operation, I earn a lakh of rupees from the patient. An operation is not without any harm. Every operation carries a risk. So I'm willingly doing harm to the patient so that my bank balance will swell. And this is unethical. The last principle is justice. This again appears to be very self-evident. No? We have to be just as far as our patient is concerned. But sometimes this is difficult. Let me give you an example. I'm working in a tiny little clinic in a village, which is very far from the nearest town. In this tiny little village clinic, I have set up a small ICU with one bed. It has only one bed. And that one bed has one ventilator, which can be used if it is necessary. At the very same time, two patients are brought to this little tiny clinic in a village. One of these patients is a very, very poor patient. He's actually in rags and tatters. He hasn't had a bath for 10 days, and he really stinks. But he has an illness which, if he is treated, it will save his life. I'm taking the example of barbiturate poisoning. If this barbiturate poisoning is treated, then this person will go back to normal and be able to do whatever he was doing earlier. The second patient is a VIP. He's the chief minister of the state. He happened to be passing through that area, and when he was very near my village, his car had an accident. So he was brought to the clinic. When I'm taking the history from the relatives, I learned that he is under treatment for advanced malignant cancer with widespread metastases. So the relatives show me the report from Tata Memorial Hospital that this person has got so-and-so cancer and he has got metastasis in the brain, in the liver, in the bones, everywhere. And you know immediately that whatever you do, his lifespan is severely restricted. As I told you, we have only one bed and one ventilator. Whom should I admit? Justice demands that I should admit that poor person who is in rags and tatters because his life can be saved. The minister is a gone case. He has a very short time to live anyhow. who do you think will actually get admitted in most such clinics? It will be the minister, because tremendous pressure will be exerted on the doctor, and he will eventually admit because of this severe pressure, and that poor man in rags and tatters will die. And of course, no one will ever feel sorry that he died because he didn't have anybody looking after him. Now, the book that I've referred to by Beauchamp and Childress is about 1,000 or 1,200 pages long. Everything which is in that book and everything which I've talked about so far on medical ethics is encapsulated in one very simple principle, the golden rule. What is the golden rule? The golden rule in the Bible says, do unto others as you would have others to do unto you. So if you are the doctor and he's the patient, do whatever you would do if you were the patient and he was the doctor. What would you expect him to do? Do exactly the same thing. Now, this is not a rule which is common only to the Christian faith. If you look at the center of the slide, you will find that every single philosophy on earth embodies this principle. Buddhism, Confucius, Taoism, Sikh, every philosophy you can think of has this particular principle. And on the left-hand side of the slide, you will see a quotation from the Mahabharata, which also says the same thing. So this golden rule is present in every single philosophy. And it incorporates all the ethical principles and the discussions and the debates which you can incorporate into a 1,200 to 1,400 page book and more. I'm now going to end with this slide, which is a slide which I am very, very respectful of and very fond of. Have a look at it. At first sight, what you see is that this is the home of a very poor person. It is not a palatial mansion. It has got no fancy furniture and artifacts and decorations. On the left-hand side, you can see a string on which clothes are hanging to dry. There is no sophisticated method available for drying these clothes. There is a little child on whom the lamp has been focused. The little humble lamp which is on the stool, which is on the left of the screen. And this lamp is placed in such a way that it is focused on the little child. And you know from the title, which is called, the title is The Doctor. And this is a painting which was made in 1891 by a person who was eventually knighted, and therefore he became Sir Luke Fields. Look further into this picture and see what you see. There is a bearded gentleman who's very well clothed, and he is sitting on a little chair next to the child who's the patient, next to his pediatric patient, and is quietly and peacefully watching the child. What is he watching? You can see on that table that there's a cup with a spoon in it. So obviously some medicine has been given from that cup to the child. Where has this medicine come from? There is a bottle which is 1/3 empty, which is also on that table. So the doctor has brought with him a liquid medicine which he has given to the child. And he is watching this child. He wants to know how this child is progressing. How long has he been watching the patient? It's a long time that he has been watching this patient. How do we know it's a long time? Because the light is on, the lamp is on. And this is a poor person's house where a lamp would not be kept on unnecessarily because it would cost money. So obviously, this doctor has come in the middle of the night, and the lamp was necessary for him to see the patient and treat the patient. But how do we know that it's been a long time? Look on your right side at the window, and you will see that sunlight is shining through it. So it is already dawn. The light is already coming through. There is another evidence that he has been watching this patient for a long time. Look at the lady who is the mother. The lady is exhausted. She has been looking after this little baby maybe for 2 days, maybe for 3 days, had not rested, had not slept. Now that the doctor is here, she is taking a little bit of rest. And look at the husband, the father. He's gently watching what the doctor is going to tell him next. Now, this shows all the attributes of a good doctor. The good doctor is patient with his patient. The good doctor is concerned about his patient. It doesn't matter to him that he's been sitting half the night watching this little child. He's in no hurry to run away. His only concern right now is that this child should show evidence of improvement. And that is the ideal physician, the ideal to which each one of us should aspire. At any given moment, when we are facing a patient, that patient is the center of our attention. He is the only person in focus. In this age, in 1891, of course, there were no telephones. But if this same doctor in 2022 was in this kind of a position, his mobile phone would be shut off, because that would disturb his observation of a very obviously sick person. I cherish this painting, and every time I look at it, I learn more and more from it. It is a very common painting. It's very easy to get a copy of this. I suggest that every one of you tries and gets a copy, and try and keep it in front of your consulting on your consulting table, so that every time you see a patient, you are reminded about the way in which a good doctor treats that patient. I'm leaving you with this list of suggested reading, which may be of some help. And since this meeting is being recorded, eventually all of you will have access to the recording. You can have a look at these references which I have provided. Let me call your attention to the second reference from the top by Francis Peabody, and it is called The Care of the Patient. This is a classic paper. It is a paper which should be read by every medical student, and the principles which Francis Peabody has embodied and described and followed should be engraved onto our minds. Every one of these books has something from which we can learn. And so I recommend these to you. And with this, I end my talk. Thank you very much.
Thank you very much, sir. And it has been a fascinating experience to listen to you. We are very young compared to you in terms of years that you have spent in medicine. What I can understand from this is you have not confined your destination to only medicine. You have been interested in literature. You've been interested in art, and not just superficially to art, but deciphering the inner meaning of the artwork that you had displayed. I wouldn't stop all the people who are kind of witnessing this from asking questions. I set the ball rolling with Dr. Ajit Kumar. Over to you, sir.
Thank you. Thank you, sir. Thank you, Dr. Sunil Pandya, for that erudite and enlightening lecture. I will, by necessity and need to ask a couple of questions and get a few answers from you. I do understand this complex and yet this simple web of doctor-patient relationship has to be dealt with care, respect, and love. And I have a couple of questions. Now, I do understand this trust that patients are keeping or giving it to us, and this doctor-patient relationship. We seem to be losing the trust of our patients when we look across time. And why is this deteriorating over time, not just in India, but just across the world, across the West as well? So, what in your reason is that we are not able to keep up this trust?
Let me try and provide a simple answer to a complex question. We ourselves are responsible in great measure for this loss of trust. When I was a student in those prehistoric days, when I was a student, the doctor was a member of our family. That was the era of family physicians, and the family physician knew every little thing about my family. He knew my parents, he knew what illnesses they had. He had probably been there when I was born. He knew about what illnesses I had as a child, and he was a member of my family. He had the best interests of my family at heart. And if ever there was a need where he felt that this was a matter beyond his competence, he would immediately recommend to my parents the very best and not the most expensive place where I should be taken or doctor to whom I should be shown. So that was the period when we really considered the physician as a part of our family. We considered him as a member of the family. Now that has changed dramatically. And unfortunately, the family physicians are now a dying breed. There are very few good family physicians around. And if you ask an average person in a big city like Bombay, who's your family physician, they'll start wondering, what family physician? Because now everybody wants to go to a consultant. And the phenomenon of distrust, which you have shown, has followed malpractices by us. We ourselves have done things which have made the patient distrust us. We have formed alliances with drug companies, and we have started prescribing very, very expensive drugs when much cheaper substitutes are available. Because every time I prescribe an expensive drug, I've got a share. Every time I refer a patient to a CT scan center or an MR scan center, I get a share. I get a cutback from that person. If I, as a family physician, send a patient to a consultant, the consultant sends me part of his fees as my cut of the fees. So we have been doing so many things that are not in the interests of the patient, and the patients have got wise to this. The patients have realized, look, this is what my doctors are doing. So what do you think happens now when somebody needs an operation? So I'm a neurosurgeon. He comes to me. I tell him, you need a brain operation. You think he will immediately say yes or no? He will say, no, doctor, that's very nice. Thank you for explaining all this to me. Now I have to go and discuss with my family, and I have to just see what I have to do. You think he goes and discusses only with the family? He goes to consultant number 2, number 3, number 4, number 5, number 6. Only when all of them say that there is no other solution, you have to undergo an operation, then he will choose between these 6 surgeons as to who is the one who is least likely to cheat him. And this is something which has happened. Unfortunate it is. But I have a feeling that if you yourself are true and honest, the chances of this kind of distrust being shown to you will be minimized. They will still not accept your decision as final. They will still consult 4 other consultants. But ultimately, when they accept an operation has to be done, they will come back to you and say, okay, sir, now I am willing for this operation. Please go ahead and do it.
Dr. Sanjay, sir, would you?
Yeah. So thank you so much for this wonderful lecture, sir. I mean, you're so inspiring to all of us all the time. I mean, I've been watching you from the time that I was a very young neurosurgeon, and from then, nothing has changed. I mean, this inspiring lecture that you gave is exactly the way you are. And one small question that I have here is, sincerity versus the responsibility is an issue. We have, I mean, a doctor is supposed to be sincere, and yet he's also responsible for other people in his family, his friends, his colleagues, and this sincerity often, interferes with, uh, the responsibility towards his near and dear ones. So, is it unethical to actually continue to be sincere?
I don't think there's any option to being sincere.
Sincere towards profession, which interferes with your commitment to your family, which we've all done.
You have no alternative to being sincere. The only additional suggestion that I may have is that you can voice or phrase your answers to their queries in such a manner that they don't hurt, they don't feel insulted. At the same time, your answers do not veer away from the truth. All your answers are truthful, but they are made in such a way that they don't hurt, they don't make that person feel uncomfortable, they don't make that person feel that you are antagonistic or anything like that. Gentle and courteous phraseology, but absolutely with truth at the core.
Thank you.
I don't know whether this is practical under all circumstances, but this is what I would endeavor to do.
Yes. There's another question there there's another question in the chat box.
Yeah, actually, so I was about to say that. Ajit sir, have you finished?
Yeah. No, please go ahead. Yes.
Yeah, the clinical faculty here have shared some of their dilemmas, ethical dilemmas while practicing medicine. These are all real life situations. Dr. K.M. Krishnamurthy from the cardiology department has asked this question. Is it okay to treat a patient with a high risk, complicated heart disease in a newborn child? The child grows up to adolescent, committed to multiple surgeries, poor quality of life, expense involved when parents are no more, reduced marriage and career prospect. Is it okay to treat or leave him to die?
This is a very, very, very difficult question. Actually, this problem starts whilst the baby is still in the uterus. Because with the current modalities that we have, very sophisticated ultrasonograms and CT-MR, whilst the baby is still a fetus, make it possible for us to detect some of these abnormalities in utero. And so the question can be asked while the baby is still in utero. And as soon as the diagnosis of a complex abnormality of the heart has been made in utero, this question can be asked. And under the laws of the land, there are circumstances under which the life of the fetus can be terminated, because the abnormalities are so severe that it is unlikely that this person, the baby, will ever lead a happy and healthy life. And as you point out, the baby will have to be subjected to operation after operation after operation after operation. Whilst this is difficult even for a well-to-do person, when the family is a poor family, abjectly poor family, then the situation becomes even more grim, because such a family cannot afford all these management of the baby with the cardiac deformities and of course the multiple operations which will be required. So it's a very complex situation, But under the laws of our land, we are disallowed from terminating life except in a certain in utero period. That's the only time when legally we are permitted to terminate life. Otherwise, we are not permitted to terminate life.
Okay. The next question. I'm sorry, sir. Have you done?
Illegal to do it.
Can I?
Yes, please.
Can I get the second question? The second question is again another clinical setting. This question has come from Dr. Ravi Prasad Verma of the Achyuta Menon Center of Health Sciences. A patient may have repeatedly insisted on do not resuscitate, but later brought to the hospital unconscious, and the relatives insist on resuscitation. A past statement of autonomy, is it sufficient for a decision in the future?
Very, very, very interesting and a practically important question, because this happens in practice. According to the law as is practiced in Western countries, if a person has made a do not resuscitate document whilst in full possession of senses and without any compulsion being exerted on the individual, then this document is sacrosanct. You cannot violate this document, because this is the patient's directive to you, made at a time when the patient was in full possession of his senses. And if he has said that usually this do not resuscitate has certain conditions. Do not resuscitate if I am unlikely to lead a meaningful life, if I am brain dead, etc., etc., etc. So if those conditions are met, then you cannot resuscitate this patient, no matter what the family says, because this is a document which that patient has written, and it's a patient's directive to you. In India, the matter is still somewhat fluid. There is a definite move towards making this DNR and other such applicable within the legal framework. But what most consultants and the administrative heads of institutions find practical is to put this matter before a sitting judge. Take the facts, put them before a sitting judge, and say, what shall I do? Shall I follow the patient's directive, or shall I follow the family's directive? Now, why do these Indian consultants and Indian administrators do this? Because if a case is filed against the hospital, then the hospital can get into a really long and troublesome and expensive litigation process. So they find that it is much safer to preempt all this by taking the matter themselves to a judge and say, look, this is a situation. This is the condition of the patient. This is the likely outlook. This is what the directive says. This is what the family says. Please tell me what I should do. And judges sometimes are quite fair and honest and decent, and they take this up as an urgent request and will give you an urgent answer.
Thank you, sir. The next question has on the chat box is from Dr. Prakash Nair, neurosurgeon again. In case of children or minors, if parents choose a course of treatment detrimental to the child's health, what recourse does a physician have? There are instances when we tell the parents that the child requires surgery. They might take the recourse of a faith healing or alternate forms of therapies. In that case, how far can one insist?
Actually, the clinician is responsible for the patient whilst the patient is under the clinician's care. Once the patient goes out of the patient's clinician's care, it is no more the responsibility of the clinician. So I'm just taking an example. The patient is admitted under your care or under my care. And I tell the patient's relatives that, look, we have done everything possible. Nothing more can be done. And I'm sorry, but your patient is going to remain like this. And the patient's family says, okay, doc, please discharge the patient. So I discharge the patient. Now what they do, whether they go to a faith healer or to a shaman or to a Vaid or whoever, that is their business. It is up to them. They can do whatever they want.
Okay.
The difficulty arises when the patient is still in hospital and they say, I want to bring this faith healer or I want to bring this shaman or whatever. That is when the difficulty arises. And I think that is when we have to be firm and say, as long as the patient is in this hospital, we can only carry out treatment for which we are responsible. If somebody else is going to carry out the treatment, I can't be responsible for that because he's carrying out the treatment. And that is better done outside this hospital because this hospital will not permit a third party coming and treating the patient.
Thank you, sir. And one last question before we sign off today evening. We all practice, on many occasions, a soft form of paternalism, which may interfere with patient autonomy. Is it all right or is it wrong? Many a times doctors are expected to take decisions for the patient's family.
Yes. There are two alternatives which are available. It is up to the individual clinician which option he or she is going to take. I will give you some very good examples. There are extremely eminent individuals. I don't know if you have heard the name of Dr. Farooq Udwadia, who is a physician in Bombay.
Yeah.
He's a nationally, even internationally recognized physician. And he has gone on record in print that paternalism can and should be questioned. But there are instances when paternalism is justified. And he has given examples in print. He has given an example of how a patient had arrived in a state where the doctor's opinion was that nothing should be done. But the family and the patient, who was still conscious, said, no, doc, you have to do everything that is possible. You have to go ahead and do it. And if he had been very strict, he would have followed his own inclination. But in this particular case, because of the family and the patient insisting that something should be done, he went ahead and did what should be done, and the patient did well and survived. So there are instances when it is better for us to follow against our own instinct what the patient and the family wants. The reverse is what is paternalism. When the patient says, or the patient's family says, nothing further should be done. We feel that this patient is dying and we don't want to do anything. But the doctor knows that if he takes certain steps, there are reasonable chances that the patient will do well. Not 100%, maybe 5%, but there is a 5% chance that the patient. So then the doctor goes against the instruction of the patient and the family and does whatever he could. And Dr. Udwadia has recorded instances where the patient had done well, survived, and later on gone to tell the doctor, doctor, you were right in overruling what I and my family told you to do. It is because you overruled that I am alive and I'm doing well. Similar instances have been recorded in print. I'm talking about in print by Dr. M.K. Mani of Madras. I think you know Dr. Mani. He's a very, very famous nephrologist, very famous for his ethical principles. And he has also recorded instances where paternalism was fully justified and where the patient later came and told him, doctor, I'm grateful you did not follow my instruction and I'm thankful to you. And because you did not follow my instructions, I am alive and well. Thank you.
Thank you very much, Dr. Pandya. And it's been a revelation for us as you share those wise words with us. your years in neurosurgery and medical profession with us. We've come to the last leg of this lecture, the first of the Samvaad series of lectures hosted by the Sri Chitra Tirunal Institute for Medical Science and Technology. I call upon Dr. Mala Ramanathan from the HUMANE Center for Health Science Studies to deliver the vote of thanks for all that has been done today.
Good evening. This short and yet profoundly inspiring lecture session has come to an end, setting us on the path of continuing engagement with learning. I would like to thank Dr. Sunil Pandya for delivering this lecture, responding to the request and talking about the two things close to his heart, humanness and the doctor-patient relationships and how they ought to be. It was a learning experience for all of us. The director, Professor Bihari of Sri Chitra Tirunal Institute, has been with us through the organization of this lecture series, encouraging us to formulate it and providing us with timely inputs to make it possible. The Dean, Professor Ajit Kumar, our academic leader, is the person who facilitated the development of the architecture for this lecture series. He has introduced the series and also taken on the responsibility to be a panelist. We are grateful to you, sir, for taking on these multiple responsibilities and steering us through the administrative requirements for the conduct of the series. Professor Ishwar, Head of Department of Neurosurgery and Chairperson, Public Relations Committee, Sri Chitra Tirunal Institute for Medical Sciences and Technology, has taken the responsibility of being a panelist and also the Master of Ceremonies for today's lecture. We need to place on record our gratitude for the efforts to ensure smooth communication across different stakeholders who make this event possible. The computer division of Sri Chitra with Mr. Suresh Kumar B, Ms. Geeta G and others, and Mr. Sajit Lal from the BMT wing helped to ensure the smooth conduct of this online event. The PRO of Sri Chitra, Sri Gangadhara Sharma, ensured timely dissemination of the links to the meeting to all concerned. My colleagues at the Indian Journal of Medical Ethics, Meenakshi de Cruz, Ms. Sandhya Srinivasan, and Dr. Jasani helped me to put together a bio note of Dr. Pandya, who is also the founder editor of this journal. I would like to place on record my gratitude to them for making this possible. Friends and colleagues at HEAL, the Center of Ethics Yanapoya, and at Drishti Sangat helped to share the links to this lecture across all networks. There are other women who also work behind the scenes here at Sri Chitra to make this series possible. Ms. Sri Priya CS at the director's office shepherded all the required permissions through the system, and Doctors Kamlesh Gulia and Anugya Bhatt, who with sisterly solidarity helped to revise the operating procedures for this lecture series and have actually given the series its name, Samvaad, a talk between equals when we strive to bring interdisciplinary dialogues across sciences and humanities. Last but not the least, we are grateful to the audience, my colleagues from Sri Chitra Tirunal Institute for Medical Sciences and Technology and the IJME, and from elsewhere, friends from elsewhere, for listening in, all of you who stayed to hear this wonderful lecture on a Friday night. Without all of you, this lecture would not be the success it is. Thank you all. Good night and Jai Hind.
So, thank you again. We sign off here.